Hello everyone, my name is Asma Khalil. I'm a professor of fetal medicine at St. George's Hospital in London. I've been fortunate to lead on the ISUOG guideline on the role of ultrasound in congenital infection. This guideline covers CMV infection, toxoplasma, parvovirus, rubella, varicella zoster virus or chickenpox, and Zika virus. And it was published in July 2020 in the White Journal. And I'm planning to give you a flavor on some aspects of the recommendations related to congenital CMV infection. So how do we diagnose maternal primary CMV infection? Well, the diagnosis of primary CMV infection is made by one of two findings, either seroconversion, so the maternal blood with CMV IgG negative and becomes IgG positive, or the detection of CMV IgM antibodies with low IgG avidity. How do we interpret the IgG avidity? Well, if you have high avidity, so for example, above 60%, that suggests an infection that occurred more than 3 months earlier. However, if you have low avidity, that means infection within the preceding 3 months. If it's less than 15%, within 6 weeks, and less than 35% within 12 weeks. Why we don't rely on IgM antibodies to indicate a recent infection? Because it can persist for months after primary infection. It can be detected in secondary infection. It can be positive as cross-reactivity with another virus infection, and also could be elicited by polyclonal stimulation of the immune system. What about maternal non-primary CMV infection? Well, it cannot be excluded using serology. And therefore, in order to diagnose congenital or fetal CMV infection, we need to perform amniocentesis and look for the CMV PCR. And the timing of the amniocentesis is very important. It should be delayed until 8 weeks from the maternal infection, and ideally after 20 weeks gestation. And it's important to realize that the most significant risk factor for a false negative amniocentesis is the fact that we did the amniocentesis too soon. So the interval less than 8 weeks or gestation less than 17 weeks. Once you make the diagnosis of fetal CMV infection, then the most important aim is to determine or predict the risk of symptomatic neonatal disease. And in order to do that, we have 3 important prognostic indicators: the timing of maternal infection, the presence and type of fetal abnormalities, and laboratory parameters. The general rule, the chance of fetal infection or vertical transmission tend to be higher at the later gestation. So in first trimester, preconception first trimester is 30% compared to 65% in the third trimester. It's the opposite case when you look at the chance of having severe symptoms at birth. The chance is much higher if the infection occurs early, like in the first trimester, compared to negligible risk in the third trimester, as you can see from these figures. What about the fetal abnormalities? Of course, finding severe brain abnormalities is consistent with the fact that the baby will have symptoms or neurological sequelae after birth. However, having normal brain findings on ultrasound and confirmed with a fetal brain MRI are usually associated with low risk of infant disability, but this is not indicative of hearing outcomes. The other important fact is that we need to realize that the ultrasound abnormalities can appear up to 12 weeks or even longer after the maternal infection, and therefore we need to follow up this pregnancy with detailed ultrasound scan and potentially repeating the MRI. What abnormalities that we can detect? Well, it can be grouped into cranial, extracranial, and abnormalities that affect the placenta or the amniotic fluid volume. This is a list of the cranial abnormalities, which varies from ventriculomegaly, intracranial calcification, microcephaly, intraventricular synechia or adhesions, periventricular cyst, cerebellar, as well as cortical abnormalities. And you can see some of these ultrasound features showing the cyst, showing intraventricular adhesions or pseudocyst, showing lissencephaly and ventriculomegaly, showing cerebral calcification, white echogenic spots, Extracranial abnormalities include small gestational age, echogenic bowel, hepatosplenomegaly, liver calcifications, ascites, or hydrops. Abnormalities of the placenta or the amniotic fluid volume include sick placenta, placenta calcification, oligohydramnios, and rarely polyhydramnios. What about the value of laboratory parameters? Despite the fact that the viral load in the amniotic fluid or the fetal blood or the platelet count have been associated with the risk of symptomatic infection, it's overlap between the group that have symptoms and the group that don't have symptoms, as well as the technical and temporal factors, reduce its prognostic value compared to the presence of abnormalities, for example. And therefore, that makes the role of fetal blood sampling in the prognostic workup of these cases is not certain. After detailed assessment, and you can group the infected fetus into one of the three categories: asymptomatic, green, red, severe, and the orange is mild, moderate. So the asymptomatic, no ultrasound, no brain abnormalities, prognosis generally good with a residual risk of hearing loss. The red, the severe, there are severe, particularly brain abnormalities associated with poor prognosis. And the orange, the mild, the moderate, there are some abnormalities, but not in the severe spectrum. And therefore, the prognosis is uncertain. And in this group, you could potentially consider therapeutic options, but also could consider the option of termination in view of the progressive nature of the infection. And what about potential therapeutic options? So the val-acyclovir was reported in this phase 2 study, multi-center open label, to reduce the risk of symptomatic infection or increase the proportion of asymptomatic neonates from 43% to 82%. This study, which was not a randomized controlled trial, however, is really important because it's provided reassuring safety of the use of val-acyclovir in pregnancy, particularly the high dose, which is 8 grams per day, with a good maternal tolerance and with no adverse neonatal effects. However, as it was not a randomized controlled trial, the recommendation is that high dose val-acyclovir should only be given in the context of research in cases of congenital CMV infection after obviously counseling of the parents about the evidence. What about immunoglobulin? Based on the results that we have from randomized controlled trial, shows lack of efficacy and potential safety concern, and therefore its use is not recommended in routine practice outside the context of research. This flow chart is included in the guideline document, and I find it very useful to guide you through the management depending on the findings. What about prevention? Well, we have evidence that behavior modification aiming at reducing the risk of maternal CMV infection in the first place could be beneficial, and that's mainly reducing contact with body fluids, as saliva or urine of young children. There is recent evidence from randomized controlled trial that in women with maternal primary CMV infection in the periconception period or the first trimester, that if we give oral val-acyclovir, again the high dose, so 8 grams per day, reduces the risk of vertical transmission by about 70%. And therefore, if you look at prevention of congenital CMV, well, primary is reduced maternal CMV infection in the first place through education. Secondary prevention is once the mother had the infection, reduce the vertical transmission. And there is evidence from a randomized controlled trial that giving the val-acyclovir of high dose reduces the risk of transmission by 70%. There's no evidence to support the routine use of immunoglobulins. And for the tertiary prevention, so once the fetal infection is confirmed and there is some evidence of mild, maybe abnormalities, the use of val-acyclovir could potentially be beneficial in reducing the risk of symptomatic disease. And we do have evidence from randomized controlled trial on the value of giving postnatal treatment with ganciclovir to reduce the sequelae. So I'm going to stop here, but this is a flavor of what's the content of the ISUOG guideline on congenital infection. The document is written in a very easy, practical language with clear recommendations, and I really hope that you enjoy reading it and finding it useful in your everyday practice. Thank you very much.